Since diabetes, and more importantly, prediabetes is the major cause of plaque and inflammation, it's by far the major cause of heart attack, stroke, blindness, kidney disease, all those bad things that are associated with chronic disease. And a lot of folks don't know that. That's one of the key goals of this channel, is to make people aware. 90% of the people that have prediabetes aren't even aware of it. The CDC, for example, has said in different episodes and different pages, they can't decide whether 80 million or 100 million of Americans have prediabetes or diabetes. In other words, about a third. Well, you know, that number is probably low. If you look at a study by the University of California at Los Angeles a couple of years ago, they saw that this is not just a problem that happens to 60-year-olds. And it's not just 1 out of 3. It's 1 out of 2. And it starts in the 30s. So 1 out of 2, 1/2 of Californians 30 and older have diabetes or prediabetes. In fact, more than that. It's more like 54%. And you know what's very interesting? When you look at how that information is collected, that's basically based on hemoglobin A1C and fasting blood glucose. Now, a whole lot of viewers of this channel know something very interesting about that. Excuse me just a second. A whole lot of viewers know that hemoglobin A1C and fasting blood glucose significantly underestimate the problem. So it's probably bigger than half. As you start looking at things like the Freestyle Libre, continuous glucose monitoring, as that's becoming more affordable, we're finding people that we thought had rock solid glucose metabolism really don't. So it's no wonder why so many of us have plaque in our arteries. That's what causes it. So today we're going to talk about a topic that's really important for this area. If you know that you have prediabetes, thank your lucky stars, because again, for every one of you that knows, there's 9 or 10 that don't. But if you know that, you may have heard your doctor say, well, you know what? You can grow back those beta cells, those islets of Langerhans, those cells that make insulin in your pancreas. You can grow them back. Well, I've heard that a lot. The reality is that's probably not what's going on. Now, I talked about this whole mechanism a couple of weeks ago in YouTube Live, and I think it was one of our viewers, I think it was Bob Bell, sent me an article that documented exactly what I was talking about. It has to do with the fact that for most of us, the first thing that we lose in an insulin response is that first phase, that primary phase. In other words, we start having problems controlling our fasting glucose. Instead of remaining at an optimum 5 or lower, our insulin has to go up to 6, 7, 8. I've got patients who came to me with a fasting insulin or basal insulin over 10. That's a big problem, because then those pancreas cells don't have any more insulin to store, so they lose that first phase of the oral glucose tolerance test, that first phase of insulin. They have to make it. There's no stored insulin there. We're going to get a lot deeper into that today. It helps us understand exactly what's going on with prediabetes. Before we do, though, we'll go through some other content that we have available. We always do that. We talked, I think it was last week or the week before, about 5 supplements that can boost cardiovascular health. Supplements is always a very popular topic. I've seen a ton of interest in this article on Vascepa or Vascepa, depending on how you pronounce it. It's that super duper fish oil. And the big question on Vascepa is this. We used to know for sure if your triglycerides were 500 in that area, you really needed this type of fish oil, the supplemented type, not regular supplements, but the prescription level type. Then recently, just over the past year, science has indicated that if you've got heart disease and your triglycerides are 150, not 500, but 150, which a lot of people have, then you should probably consider Vascepa. A lot of the discussion at that point went to, well, what if I'm at 100 or 110 and I have heart disease? What should I do? So there was a lot of discussion about that. Other topics we've covered, the triglyceride over HDL ratio. Again, we've got plenty of patients. One of them, I think the one that did the video for us was a fellow named Chuck Smith. He saw one of the low-fat docs, Caldwell Esselstyn, got that fat out of his diet, lost 50 pounds. And for most people, that's a life-saving event. But for Chuck, it wasn't. Chuck had a heart attack after losing 50 pounds on a low-fat diet with Caldwell Esselstyn. So I'm not throwing stones. The folks that talk about low fat have saved a lot of lives. Anything that can help people lose weight, for most of us, weight is the most important thing. But for a lot of us, that triglyceride over HDL ratio is critical. And again, Chuck had a heart attack after that. So he told his story. The two videos that we did there got into a lot of detail about exactly why does that happen? Why is triglyceride over HDL so important? What makes the triglyceride go up? What makes the HDL go down? And how can you manage that? And again, spoiler alert, if you go back to take a look at those, carbs have a lot to do with the triglyceride over HDL ratio. Vitamin K2, always a popular topic with this audience. And there you go. Getting increasing interest in our webinars. The webinars are a great way to begin to understand, am I one of those 90% of people that have prediabetes and don't know it? Because most of us have been depending on our docs. And again, I'm not throwing stones. It's just, you look at the science. The science is really clear. The folks at Hopkins have documented that the vast majority of primary care docs, the folks we're depending on to help us diagnose prediabetes, don't know how to do it. So if you want to get a quick, easy understanding of whether or not you have prediabetes, check out the webinars. Very simple, easy way to get this done. Even simpler, even easier are the courses, help you understand what is cardiovascular inflammation. We've done a couple of videos recently. You'll see them coming out. It's easier to understand. I don't have it anymore, but I had some inflammation on my skin here. And you see people with psoriasis. You look at that inflammation, that oozing, the bleeding, and you understand clearly the immune system's attacking. But when you hear about cardiovascular inflammation, it's harder to connect those dots because you really never see the inside of an artery unless it's on an autopsy or something like that. So we get into a little bit of detail. Once you take these courses, I think they're on sale right now for less than $20. $20 and less than 2 hours time, you're going to know a lot more about cardiovascular prevention, inflammation, insulin resistance, plaque, than 95% of doctors. So great, easy, inexpensive way to get there. Speaking of inexpensive, we know that our routine services are up there. They're expensive for a lot of people. And a lot of people need some help budgeting. There have been a lot of requests to set up subscriptions. We've set those up. Those are, again, gaining a lot of momentum. There's a couple of ways of seeing us, getting access to our full content, and seeing me as a patient as well, using the subscription plans. How many times have I said, writing a book with a co-author is a headache? Todd still has it, not sure where he is with it. We have started to put a lot of that content out there for free and make it easy to access. I put a good bit of that content in a web blog. It's on our website. Just go to prevmedhealth.com and look for blogs, and you can find a lot of this information about what a stress test can't tell you. As you know, Tim Russert's the poster boy for that. He had some problems with his diet. He was gaining weight, having some problems with his blood pressure. Got a stress test. He and his doc said, "You're good to go." Went back to work. 2 months later, had a heart attack and died. So this goes into a little bit of the science and the understanding of why that happened. And even more importantly, what you can do about it for yourself to avoid that. So we talked about the website. Again, we're getting a lot of, it used to be an old, ugly website. It's still not the greatest, but it is a lot better. And a lot of people are spending time on it, starting to get that content that used to be available only on these videos. So once we get the water ball, we'll start with our program for today. So a couple of people have already responded saying, "Oh, this is an interesting topic." And again, as often happens, I learned a lot of stuff. I learned about a lot of things from you guys. I think it was Bob Bell, one of our viewers, that sent me this. It sent me several other things as well. This again is a study that appeared in a journal called Cell Reports. It's a fairly deep scientific journal. It's called, here's again, deep scientific title, but we won't get too deep into that. Dysfunction of persisting beta cells is a key feature of early type 2 diabetes pathogenesis. What does that mean? Here's the bottom line. Here's what they did. They happened to be in the belly of a lot of surgical patients for other reasons. They had a mechanism, and the patients gave prior agreement. They took some patients that had normal metabolism, some that had full-blown type 2 diabetes, and some that had prediabetes. They took tiny biopsies out of the pancreas and the beta cells to look at those beta cells and find out just what's going on. Are the beta cells, are you losing beta cell function, or are the beta cells actually going away? In other words, going back to that question of, you can, quote, grow your beta cells back. Again, this, for a spoiler, I'll say, look, this would indicate what many of us have thought for a long time. It tends to provide a lot of evidence, a lot of proof that you don't lose those beta cells, and they're not shrinking, they're not getting attacked, they're not being lost. The size is still there. Now, let me clarify. This is type 2 diabetes. As many of us know, type 1 diabetes is a whole different mechanism. It tends to happen with very young people, whereas type 2 diabetes mostly hits us baby boomers. With type 2 diabetes, the original problem is our receptors for insulin in our cell wall get rusty. They begin to become resistant to insulin. So our beta cells, you can get my nonverbals here. So the beta cells are having to push out more insulin to get those faulty, rusty, dysfunctional insulin receptors in the cell walls to work. With type 1 diabetes, it appears to be, for the most part, immune activities, inflammation actually hitting the beta cells themselves, usually cross-reaction with something else, a foreign body. Won't go into that any deeper into that. We'll talk a little bit more about the study itself. So here's to the script. Type 2 diabetes is a metabolic disorder responsible for long-term complications, decreased quality of life, and premature death. Type 2 diabetes is characterized by insulin resistance and insufficient insulin release from pancreatic islet beta cells. To correct inadequate insulin levels, effective therapies target the correct mechanism. In other words, why is this important? It's still debated whether insulin insufficiency is the result of compromised beta cell function, in other words, the amount of insulin released by each individual beta cell, or reduced beta cell mass, in other words, the number of beta cells within the pancreas have decreased, or a combination of both. And again, I'll keep giving you spoilers. It was the first one. It's not the second one, and it's not a combination of both, at least according to this study. And again, I think this study makes a heck of a lot of sense once you get deeper into managing folks with prediabetes. So prior to this study, their point was, it's unclear whether the objective of type 2 diabetes prevention and therapy should be to protect and restore beta cell function or to prevent the death of beta cells and increase their mass. That was the study question. Researchers used pancreas tissue slices from metabolically phenotyped surgical patients. What does that mean? If you go back, I told you that they took 3 groups of patients before the surgery. Some were pre-diabetic, some were diabetic, and some had neither problem. So that's what they mean by metabolically phenotyped. It's, again, $2 words for a 50-cent description. They found out what they were. Phenotype means what's their body function. So they found out what was going on with these folks, and then they did the biopsies. Surgical samples were the following: 4 from non-diabetics, 4 from folks that had impaired glucose tolerance, IGT, as you'll see in some of these images, and 6 from folks that had type 2 diabetes. Subjects were part of a larger cohort of 61 people with no diabetes, 71 with impaired glucose tolerance, and 88 with type 2 diabetes. Prior to surgery, subjects were phenotyped based on hemoglobin A1C, fasting glucose, and these guys were smart enough to do an OGTT, oral glucose tolerance test, and looking at ADA guidelines. Viable tissue slices were subsequently used with, again, another technical term, 3D morphometric analysis. As usual with these big words, just break it down. Morpho means your body shape, and metrics means your measurement. So it's measurement of the shape of these beta cells. That's what that meant. And they looked at kinetic insulin secretion as well. To quantify the endocrine cell content, beta, alpha, and gamma cells, the researchers used this 3D morphometry. In other words, that's how they were able to tell what type of cell is this. Is this the exocrine pancreas cell? Exocrine means those are the cells that create enzymes for digestion. Or was this the endocrine cells, which were the beta cells, which we're focused on here? In non-diabetics, endocrine cells constitute about 48%, or plus or minus 0.09%. Let me clarify something. 0.48%. So about 0.5% of the pancreas volume. The distinct endocrine cell volume fractions of endocrine cells were not significantly altered in the pancreas of non-diabetics, impaired glucose tolerance, and type 2 diabetics. In other words, what they're saying is, you look at these graphs, and you look at the size and the portion of the mass of cells made up by the insulin cells, the beta cells. They were the same, whether it was diabetic, non-diabetic, or pre-diabetic. Neither the distribution or of endocrine object size, nor their contribution to the total volume was significantly changed. Thus, the 3D morphometry revealed no difference. In other words, we're not losing the cells themselves, we're losing the function. So speaking of function, that's what they did in the next series. To address the beta cell function, researchers measured insulin secretion. Now you see that in this over here. Let me go through what they found, and then we'll talk for a minute about this activity. In the non-diabetics, pancreas tissue slices showed a typical, the biphasic insulin secretory pattern. In other words, secretion of that stored insulin, and then later on secretion of the insulin that it made. Remember, we were talking about that earlier. And we were talking about people with impaired glucose tolerance, prediabetes, usually lose that stored insulin function. They looked at it on these cells when they took these cells out of the pancreas, and that's what was happening with the cells. In other words, they were depleted. In impaired glucose tolerance, samples showed a significantly increased basal insulin secretion. In other words, it's what we see with an oral glucose tolerance test. These beta cells are working overtime. They're not getting a rest. They're continuing to push out more insulin than a non-diabetic during basal periods, when we're fasting, when we're asleep. Somebody with prediabetes, their beta cells are continuing to push that insulin out. Why? Because that insulin's not working. Why is the insulin not working? Because those insulin receptors are resistant. That hopefully helps you connect some dots. So in the type 2 diabetes, the baseline insulin secretion was similar to that of the non-diabetic. In other words, nice low secretion. It was significantly lower than somebody with impaired glucose tolerance. And again, that's what we tend to see as well, especially with people. What happens is as your beta cells are continuing to try to manage that glucose, they have to put out more during basal periods, during fasting periods. They get worn out. They're not able to store any for that first phase. And again, as you continue to go into full-blown diabetes, you start to get depletion and fatigue of that beta cell. It's no longer making, it can't respond to the first part. And then when it gets deeper, it can't respond even to the second part. That gets into that discussion about the 5 stages of diabetes. Both impaired glucose tolerance and type 2 diabetes patients lacked the typical first phase peak prior to the second phase plateau. You see some of that here. Again, it's a little bit difficult to tell from this, but what you see is, look, the green, you see that early storage phase, that first phase, and then you get to 75 minutes, and you get that second phase where the beta cells are making insulin. With the blue, the impaired glucose tolerance patients, you see they're pushing along making insulin even when they're supposed to be at rest. So therefore, once you get to that first phase, they don't have quite as much there. They're tired. They haven't been able to store insulin. Then they're still able, though, to get a little bit of a bump in that second phase at 75 to 80 minutes. This full-blown type 2 diabetic is down in the orange. As you see, the beta cell is depleted, it's worn out. It's not producing more during basal periods. At that point, this is a diabetic, remember, that person still has high blood sugars, but the beta cell's just not able to respond to it. There's depletion, so there's no ability to respond to that first phase, and then very minimal response even at the second phase. So you see what you've got there is that what Joseph Kraft would call us, and many others would call a stage 5 insulinopenic patient, type 2 diabetes patient, a patient who just doesn't have insulin anymore to put out. So to go back to the summary, this helps us in terms of the image. Let me read through again the text components. Beta cell mass in tissue slices appears intact throughout the progression from no diabetes to prediabetes to type 2. In other words, the cells are still there. In prediabetics, impaired glucose-tolerant donor tissue, the beta cell volume is unchanged, but beta cell function is significantly deteriorating, exhibiting increased basal release, in other words, fasting release, but loss of that first phase insulin secretion. In individuals with type 2 diabetes, function within the sustained beta cell volume still further declines. This means that beta cell dysfunction develops early in prediabetes and deteriorates further in type 2 diabetes. These results indicate that the dysfunction of persisting beta cells is the key factor, not the loss of mass, not the loss of the cells themselves. So as you begin to look through this, what you begin to see is, again, a good visual. Impaired glucose tolerance, they have, again, normal glucose, but it's taking a lot more insulin to make that happen. So you get glucose values that are not that elevated, but a lot of insulin there, basal insulin, to keep it down. Then that first phase, you've lost your insulin. You are not able to create a first phase. Second phase and third, and the beta cell mass are still retained in these pre-diabetics. Once you get into those deeper stages of diabetes, blood sugar's high, basal insulin has been depleted. There's none of it for the first phase or second phase, but you still have that beta cell mass. There's a lot of promise in that, because if we can, it's easier, theoretically, it should be easier to restore function than it is to recreate new beta cells. So again, got a little bit deep. Couple of our folks on our team got a little bit confused as we went through some of this. I hope that I didn't butcher that up too much. When Aspen gives us the water ball, we'll take questions and answers. So, my BJJ, and from Temecula, California, and John Tocho, Dave Murphy, good morning. Teb Tingry, we see a lot of comments from Teb. Thank you for joining. Good morning, Doc. Some new research is saying DPP, 4Is, and GLP-1 agonists can preserve beta cell function. That's true. Those are some of the new drugs, new as in some of them over 5 years now. The GLP-1 agonists, interesting fact, they were originally discovered from the saliva of a Gila monster. Now, I wonder where that came from, and wonder how that discovery happened. BJJ, fasting insulin 1.9, excellent. The number that you want to have for fasting insulin, the optimum is 50 or less. Fasting blood glucose, 93. That's good. Excellent. You want it 90 or less, and 93 is not significantly different from 90 in terms of the tests and the tolerances for error. HOMA-IR, LP-IR, and all markers say insulin sensitivity is very good. Could I have beta cell dysfunction, or is very low insulin normal when in keto? Could it be prediabetes type 1.5? So a couple of points. Number one, I'm glad you brought up HOMA-IR. One of the things I'll say is that the vast majority of HOMA-IR calculations I've seen are just a ratio between insulin and glucose. And many people say, oh, that's the be all and end all. That's the gold standard. I tell you, when you do a full-blown insulin survey, by that I mean when you do a glucose tolerance test and you're measuring insulin at each one of those tests, you see very significant changes in those ratios. So you really need to get a static ratio is just not that helpful. You really need to get an oral glucose tolerance test. I would not trust, they have markers. I would not trust the markers. I would not trust the HOMA-IR ratio. I would get a full-blown oral glucose tolerance test and insulin at each of those blood draws. My BJJ, is it common to have good insulin sensitivity but very low insulin? I get glucose spikes to 170 after a high carb, but it soon gets controlled. I plan to get a craft soon. Yes, so BJJ, you're doing the right thing. The craft is exactly what I'm recommending. We've been able, for those of you who don't, we can help coordinate a craft for you as well. For those of you who don't want to go through the fingers blot, you stick your fingers a lot and bleed onto to pieces of lab paper, and they measure it. If you want to do it with a blood draw, we have it set up, very similar tests, OGTT with insulin numbers at your local Quest. So yes, you clearly need to get that. Now, here's what I suspect, BJJ. I don't know enough about the details of what you're doing, but I know a few things. Number one, you're getting an insulin response. You don't appear to have a great initial response, so it appears that, like the impaired glucose folks that we saw there, you're probably not getting a great first phase of insulin. But after you after you do a glucose challenge and you go up, or a food challenge, you're going up to 170. You're not getting that good first phase, but it soon gets controlled. Now, I have to ask the question, what soon means? The fact that you are getting controlled tells me that you still have beta cell function. So my guess is that you've got that impaired glucose tolerance pattern. One of the questions I would have is, have you ever gone over 200? If you have, you meet some of the criteria, some of the major criteria for full-blown diabetes. It's not a problem other than to acknowledge the seriousness of your condition. I've got tons of folks that meet that criteria. By that definition of any time over 200 glucose, that's not as uncommon as you might think. The vast majority of those patients still end up doing extremely well with nothing more than lifestyle, as in mostly controlling your carbs, by far the biggest item. Most of them also agree to take metformin. For those of us who have more significant problems, there are other medications that may help. Again, there's no prescription that's going to fix a lifestyle problem, and there's no way you can outrun a diet. So all of it gets back to making sure that you have the proper amount of calories and, most importantly, the proper macronutrients. One True Moose, is it useful to select only foods that are low on the insulin index? Will that improve insulin sensitivity over time? It may or it may not. I will tell you this. I've got tons of people which do this activity. And here's what I tend to see. If it's associated with just aging, in other words, you're 65 and your insulin receptors are getting rusty, even 6 months, a year, 2 years of low carb diets tend to not change that insulin resistance so much. But what they do, you'll hear in Jason Fung's books, he keeps saying you can cure diabetes and prediabetes. What he's talking about is not so much changing that insulin resistance as just wiping out any of the disease process. Because if you're not eating carbs, your blood sugar is not going to go up. If your blood sugar and insulin don't go up, you're not going to have the problems with plaque and all of the other problems you get with it. So I hope that helped. One True Moose. Art Berry, great information. Thanks. I was diagnosed last fall as type 2 diabetic at age 64. You know, Art, it may sound bad, but you're one of the lucky ones because so many people have it and have no clue. Dave L., good morning. Bend, Oregon. Thank you, Dave, and I appreciate you telling us where you're from. Bob Bell, any information regarding strategies to restore beta cell function? Well, I mentioned one of them in terms of not pushing on the beta cells by not stressing them with 200-300 grams of carbs every day. That's one of the first and most important things. But one thing that we see that actually shows significant reversal is loss of body fat mass. I see it time and again. I used to get most of my patients from a dental community, and since the YouTube channel has grown, by far the majority of the patients now come from the YouTube channel. And it's a very, very different population. Way over half of them are people that say, you know, they'll have, a lot of them will have not bad oral glucose tolerance numbers, not bad insulin numbers, and yet they have plaque. And the first few patients I saw like that sort of threw me. And then I began to ask them, they said, oh yeah, I lost 30 pounds. So the point behind all of that is this. Body fat mass. We used to think body fat was an inert energy storage tissue. Nothing could be further from the truth. It is very, very detrimental to our insulin sensitivity. So if you've got additional body fat, that is the most important, most reliable, and the most common way of improving beta cell function. Now, that's a great setup for the next comment. Oh, wait a minute. I'll just show you. Dave Murphy. You guys may remember Dave. Dave came on and said, yep, I'm a patient. But most importantly, he said, yeah, and I lost 135 pounds. And I think by the time you came on board, you had lost 150. So talk about huge impact on your health. Great to see you, Dave, by the way. And Dave's saying, don't forget to like. I appreciate that. I would agree. Don't forget to like. Again, this was a little bit more technical today, but we've got a lot of folks on here that obviously enjoy and understand the technical side and have some technical questions. Bob, obviously, being one of them. I just started GLP-1 antagonist, Rybelsus. Yes, very, very interested in that experience, Bob. And we'll see if it has any effect on my OGTT in a few months. Yes, I think that's also a very interesting question. Now, if any of you are familiar with significant evidence associated with GLP-1 agonists improving it, let me know. In terms of medications, there's one, it's an old school medication, but it clearly has a positive impact on sensitivity. Pioglitazone. I shared that about a year ago, I started taking it. I had a, 40 point drop in my peak insulin on my next OGTT. And this was from taking it just a few days a week for 3 or 4 weeks and then stopping again. Very, very significant impact. Pioglitazone. We've got more patients who are saying, yeah, you know, I'm familiar with the risks. Pioglitazone, like any prescribed drug, has its own risks and side effects. But you start comparing that for those of us who have serious prediabetes, significant numbers, and struggling to control it. We've lost weight. We've got a BMI in the low 20s. Or some of us just can't get to the BMI in the low 20s. And some of us still need help. Some of us, like myself, have some bad genetics and bad epigenetics and need some help as well. Thanks again, David. Oh, okay, so I think we talked about that. Mr. Mr. Y. Tully. Dr. Brewer, part one had a, Dr. Brewer patient, had a 0 calcium score and a great CIMT score. Your guy did it in LA. Oh, okay. So I'm waiting till next year to look at my inflammation numbers. So you get a whole lot of folks that come in with CIMTs because we've covered CIMT quite a bit. Unfortunately, most of them that just went to a local CIMT area don't bring great studies. There's 3 providers that I've worked with in the past that did a good job with this. You have to be beyond discipline, beyond fastidious. You have to be obsessive compulsive about some of the quality control in terms of the interrogation of the wand, the ultrasound wand, when they're looking at that carotid artery. There's only one out of those 3 groups that is available on a national basis. So I think that's what Mr. Tully's referring to. The other thing Mr. Tully's referring to is inflammation numbers. One of the key advantages, there are 2 key advantages to a good CIMT. One is you can use it on a year-by-year basis to follow impact on plaque. You can't do that with glucose. I mean, you can't do that with calcium score. Calcium scores you get maybe at most once every 5 to 10 years or so for the most part. Who wants to do that with a stress test? It's not going to tell you that much in that space anyway. And who wants to go into the cath lab and get a catheter stuck up from your groin into your heart? The other thing that Mr. Tully referred to, the other advantage to CIMT, is inflammation. That's the one easy way to look to see if you have inflammation. In other words, soft plaque. So thank you for that comment. Let me, we've got a lot of comments, and the comment section's jumping around a little bit. Mr. Tully, part 2, I've been using continuous glucose monitor 1 per month. It has kept my diet in check. That's the goal, and it's a major learning curve once you begin to realize, you know, you've been flying blind for your whole life, for many of us 60-something years, not knowing what foods were having what impact on our blood sugar numbers. Down 25 pounds in a steady way. Very, very good. Best advice ever. Thank you for that comment, Mr. Tully. Sonetti, will most low carbers perform poorly on an OGTT because their bodies aren't conditioned to clear such a high dose of glucose from the test? No, that's not the case. Is not. I mean, it's an urban myth. You also see some things about low carb. Oh, what is the term? Low carb glucose intolerance. And again, at least as a physician who does, who's done how many hundreds or thousands of these, I haven't seen that as a reality. My BJJ, per your question, never gone over 200. 170 after 1 hour. Oh, that's the blood sugars. 170 after 1 hour. After 2 hours, 130 to 144. 3 hours, 100 to 120. Yeah, you've clearly got insulin resistance, because at 2 hours, you want to be back down below 100. And again, you want to peak at 120 or less. But I've been avoiding high carbs for 15 months, so I'm curious to see if improvement now. As we said, just the act of avoiding those high carbs, that gives your pancreas a rest, the beta cells a rest for sure, but it tends not to do away or reverse resistance to insulin of those insulin receptors. Elvira and Selmy, thank the universe for you. Well, thank you very much. That's a very nice comment. Your info has saved my life. I do get chills when I read that, Elvira, and the bottom line is, you're not the only one. We get that a lot. And that's why we do what we do. We get a lot of folks who say, Doc, I took your tests. I don't have prediabetes. I have full-blown diabetes. OAG, Old Alabama Gardener. He's got a channel, and he was one of those guys. And they say, you know, after finding this out, you know, I didn't know it, my docs didn't know it, and after finding this out, I've been able to save my life. So that's what keeps us going. It's certainly not the compensation. Thank you again, Elvira. Thank you very much. There's just only how many, what, another 150 million American, you know, adults in America alone that need to know this. So we'll be doing this for quite a while. James Cantor, lower carb diet seems to keep my blood sugar lower both during the day and in the morning. Thank you very much, James. So I think, James, you've shared that in several comments that you have full-blown type 2 diabetes. And yes, cutting the carbs isn't something that just lasts for an hour or two. It lasts throughout the day. One of the key things for people that have dawn effect, DAWN, in other words, high blood sugar first thing in the morning when you've been fasting, is to make sure that you're cutting those carbs, especially in the evening meal, and cutting them actually throughout the day. Binge 3X, Benji 3X. By controlling lifestyle very well, keto, BOR in my case, don't know what the BOR is. Over time, how reversible is the beta cell function? In a way, does it matter because I won't ever go back to carb-centric diet? That is an excellent point, and it gets back to the comment I made earlier. You see it time and time again in the Jason Fung books where he says, diabetes can be cured. Well, if you cut the carbs and you're not eating carbs, you're doing the proper things in terms of diet, and yes, prolonged fasting is a big help. It, in some ways, doesn't matter. If you stay the course and you remain low carb year after year after year, decade after decade. So the reason I'm going through that point is this is not a sprint, this is a marathon. And this is not a diet, it's a change in lifestyle. I hope that answered your question. Mr. Tully, part 3. I think these are parts 1, 2, and 3 of your question. Vitamin D. I mentioned this in one of your live sessions on vitamin D. I have consistent problems when I ramp up my vitamin D with K2. I get carpal tunnel, achy fingers. Tennis elbow within a week of ramping up D3. It goes away when I stop taking it. And that, you know, that is so interesting and unusual. I have not heard that. It goes away when I stop taking it and ramp up magnesium. Very, very interesting. And when you say, when you ramp it up, what levels of vitamin D3 are you looking at, Mr. Tolan? Dave L., calcium score was over 1,000, but CIMT result is excellent. Arterial age of young adult. So yeah, you tend to see, and you can see some things that appear to be inconsistent within the CIMT. Similar to this, you can see people that have a low arterial age, but they'll have plaque, discrete plaques in certain areas, and they'll have even have some, they'll have calcification, they may have soft plaque. So what's going on there? Again, sometimes it's an issue where things have changed. People were in a major weight gain mode, laid down a lot of plaque at that point, or laid down, and then backed off, developed some calcium. More often with what you're describing, again, I think there's some, number one, there are inconsistencies that you have to work through, you have to be tolerant of, you have to understand. If you've got a calcium score of 1,000, there's no question you have plaque, your arteries have been in a mode where they have been inflamed. It's inflamed the lining of the artery wall. LDL has leaked through that inflamed lining, and you've decreased that inflammation. And when you did, that the liquid plaque went away, the soft plaque went away, and you were left with some calcifications. One of the places where you see these discrete plaques is just in places where you get some turns and some common deposits. In other words, some local arterial bed anatomy issues. Okay, Dave Murphy, still stuck at the 150. Still stuck at 150. 150 is huge. Last 5 pounds being stubborn. We've all been there in terms of, or a whole lot of us have been there in terms of that battle, that fight. And yeah, those last 5 pounds are stubborn. Very few of us have been there in terms of a 150-pound battle. To get back to that comment about does it matter or how long this goes on, I gained up to about 185 pounds when I was in college. My blood pressure, even though I was 18, went up to, normally it had been 110 over 70 or even 60. It went up to 130 over 90. I realized at that point I needed to lose weight. Over the next few years, I lost 30 pounds. And so that was, well, let's say age 20, I'm age 63. I've got a 43-year-old battle going on with food. My dad, I don't know if, I've shared this in a couple of videos. I don't know how well you can see it. This is my dad and mom. My dad was north of 250 pounds most of his life as an adult. He was my height, so 5'10", 250 pounds. A large part of his life, he was over 350 pounds. Now, the reason I brought that up is that impacts us in a couple of ways. There's a thing called epigenetics. It's been demonstrated with lab animals where if the father, in mammals, at least in lab animals so far, if the father is obese at the time of insemination, the offspring and the offspring's offspring, in other words, the next 2 generations have significantly increased risk of diabetes. So that's what we call epigenetics. Epigenetics is the librarian. If you've got 20,000 genes, you've got 6 billion base pairs, you need a real good librarian to figure out, okay, what gene do I need where and when? And that is, your body does that biochemically through a process called methylation of the DNA nucleotides. So that is one of that's connecting a couple of dots in terms of our genetics, our epigenetics, and the battle that many of us have to fight. And the fact that this battle is a lifelong battle. It's not over in a few weeks or even a couple of years. Teb Tingray, speaking of pioglitazone, I can't wait till the West gets the mixed, what is that, alpha-gamma agonists like seraglitazar. Interesting. Yeah, there's a lot of new developments. The gliptins, the GLP agonists, the SGLT2 antagonists. Robert Thompson, MD advised 1 cheat meal as my weight loss is stalled on keto diet. Good advice? She said it was a reset and shock to system. Well, I do agree with resets and shocks to system. I'm not sure that a cheat meal is one of the things I would have recommended. I would have thought about a couple of things. Number 1, can you do a day of prolonged fast or 2? Those are hard, I know. I know those are very hard. Another option, another possibility is, can you ramp up the workouts for a week? Keep the diet the same, increase the metabolism a little bit. Sonity, there is a new product that claims to restore butyrate function in the gut via DNA, sequential bacteria. It is a probiotic that claims unbelievable reduction in glucose and A1C numbers for the over-the-counter product. Well, we do know that the gut's got a whole lot to do with this. Those of you who get grossed out easily may want to close your ears. we've seen that with fecal transplants, and fecal transplants have had to happen because of things like bacterial superinfections in the colon, the gut. One of the things that we found out, and it was originally just, it was interesting. They've seen it, they've replicated this in lab animals. If the fecal donor has diabetes or prediabetes, and the receiver didn't, that fecal transplant will often result in development of new prediabetes or diabetes in the person that receives it. So that's a big deal. Now, I'm not familiar with, I'm familiar with a whole bunch of claims by a whole bunch of probiotics, but I'm not familiar with any of them that are really showing significant evidence of knocking it out of the park. Dave Murphy, Mr. Tolley, have you tried ramping up the magnesium along with the D3K2? I think that's a good question. Thank you, Dave. 5 international units a day, 25 to 40 international units per week. I ramped it up for COVID, also tested at 20 vitamin D2 years ago. So I need to supplement. Yeah, if your blood level is 20, you do need to supplement. And you say working inside, I will tell you, this, I know that's a huge statement. You know, you get outside, sunshine's going to do this. There's significant variation in our ability to respond to sunshine to make vitamin D3. As we age, that tends to deteriorate. If we're a person of color, it tends to be harder because the melanocytes, the melanin, tends to filter out some of that. And just genetically, we get variation. So please don't depend on this. Again, another urban myth that you can go outside and that's going to get you where you need to be. Mr. Whiteley, Dave, I take a max amount of magnesium per day. Carolyn Dean's Remag, super absorbable. Take to a bowel intolerance. Thanks. Hi, Doc. Do you have any thoughts? Chuck K. Do you have any thoughts on reducing carbs, keto, in people in their 80s? Any downsides other than the pain of change? Keto is extremely popular, and it brings with it some interesting definitions. I don't argue with people too much about their diet. I don't carry a flag about, no, it's got to be low fat. Obviously, I don't think it needs to be low fat. It's got to be low carb, and obviously I do think it usually tends to be better low carb if you can't digest carbs. But I don't get to, a lot of people want to go full-blown keto. You get some challenges with it. There was just a news article about an Indian actress who died with, quote, due to her keto diet. First of all, I'm a little bit skeptical, but that we don't know everything that was going on with that actress. I don't think that keto is dangerous. Here's the thing. I think you need to count the number of carbs that you're taking. And in the typical standard American or standard Australian or standard diet, you tend to get 200 grams of carbs and more. The first place to start is getting them down to 100. And I may have gone way around my elbow to get to my thumb on that answer, but after getting back out, popping up out of that bunny hole, the bottom line is, yeah, 80-year-old folks, I've got plenty of 80-year-old folks who drop their carbs significantly. Start with dropping them below 100, and then you can go further. So I hope that helps. Thank you. It was a great question, Chuck. Mr. Tully, lifelong battle with food. I think you're quoting me on that. There is no free lunch in nature. Eating and living like a king is not as easy and healthy as one would think. Thank you so much, Mr. Tully, and thank you guys for your interest today. We're at the end of our comments and questions, and we're at the end of the hour. So again, thank you for your interest.